And good afternoon, everybody. Thanks for being here on a Saturday to learn about cannabis science. It's one of my favorite topics, and appreciate everybody coming to hear me speak today. So my name's Dr. Marion McNabb. I'm the president of the Cannabis Center of Excellence. We are a 501c3 nonprofit that was established back in 2018 and serve as an organization that virtually brings together citizens, medical patients, academics, researchers, policymakers, and the cannabis industry to conduct studies, educational programs, and document best practices. So I'm really grateful to be here today to present the results of a research study called iCount, Cannabis as an Alternative. Really grateful to be presenting on behalf of my co-investigators, Dr. Peter Grinspoon of Mass General Hospital and Harvard University. He sends his apologies. He's unable to be here today, but really would like to. And also would like to acknowledge my co-investigator, Eva Rachel Tyne, who is a master's in social work, trauma, harm reduction specialist, and co-chair of the Massachusetts Mental Health and Substance Use Working Groups. Big shout out to Kristen Rogers and AR Wellness for the funding and support for this study to actually happen. So let's get into it. For this presentation, I will cover a little bit of the background about the opioid crisis here in Massachusetts and the role that cannabis could potentially play as a harm reduction strategy. Then I'll launch into the study, iCount, Cannabis as an Alternative. What were our study objectives? What were the methods? And then we'll deep dive into some of the results and what are the implications of these findings. So, just to give a little bit of background, I've been studying cannabis since 2018. This is the 8th research study that I've been the principal investigator of. And there's a reason why I'm talking today about opioid use, the opioid crisis and cannabis as a harm reduction alternative. It's the result of results from the previous 7 studies that I've conducted since 2018. So, right now in Massachusetts, this study was conducted from August to November of this year. We actually just completed data collection last week, and it's a time of crisis and the need for interventions to address the growing opioid epidemic and its intersection with the growing homelessness crisis here in Massachusetts. In 2022, the Department of Public Health reported that opioid overdose deaths increased by 2.5% from 2021 to 2022, and we have the largest increase in opioid overdose death rates, disproportionately impacting Black males and Black females in the Commonwealth. Among those who actually overdosed in 2021 to 2022, fentanyl was present in 93% of the fatal opioid overdoses, and a new, very concerning synthetic drug, xylazine, was present in 5% of all of the opioid-related overdose deaths in 2022. Males comprise of nearly 75% of the overdose deaths rates, and 47% of these deaths were actually in people between the age of 25 and 44 years. So some of the most productive years of our life. We're very lucky that we have Governor Healy here, who actually was a leader in the United States in suing the Sackler family and the company Purdue Pharma and their consultants for starting the cause of the opioid epidemic. And in 2020, Governor Healy worked with the legislature to create a trust fund to dedicate resources to the prevention, harm reduction, treatment, and recovery efforts in the state. In 2021, Governor Healy announced the resolution of claims against the 3 largest drug distributors and now is distributing $600 million within the Commonwealth to address our growing opioid crisis in terms of addressing substance use prevention and treatment funding. So now let's dig into what is some of the existing evidence related to cannabis as a harm reduction alternative. More and more, if you Google if you go onto PubMed, which is searchable for all of the peer-reviewed publications, you go on Google Scholar, you'll see more and more publications, peer-reviewed publications coming out talking about the role that medical cannabis can play in a variety of capacities to address the opioid epidemic. And as we see even this year, just more and more publications are coming out, both from a clinical perspective, providing options for clinicians to integrate cannabis within opioid treatment programs, but also at a public health level and a population epidemiologic level, seeing decreasing trends of opioid prescription writing and decreasing death rates with increasing availability of medical cannabis and legalization of adult use. My dear colleague, Dr. Peter Grinspoon, recently published a book called Seeing Through the Smoke, A Cannabis Specialist Untangles the Truth About Marijuana. He himself has lived experience with opiate addiction and is currently a primary care clinician at MGH and Harvard. We recently were fortunate to have the opportunity to do a book launch event that was aired on C-SPAN, where we drilled down into one specific chapter of his book that I will like to cover a little bit today, which is really about the role that cannabis can play in clinical treatment of opioids. And so I'd encourage you all to watch our C-SPAN episode if this is of interest. But I'll quickly drill down into the 5 ways that Dr. Grinspoon believes that cannabis and cannabinoids can impact opioid use. The first is introducing cannabis or cannabinoids as a first-line therapy instead of opioids for new patients. The second is to transition existing patients from opioids to cannabinoids. The third is to use cannabinoids to lower the dose needed of opioids. The fourth, cannabinoids can be very helpful in treating the symptoms of opioid withdrawal. And fifth, cannabinoids can serve as an adjunctive therapy and harm reduction method. And I lay this all out prior to sharing the results of our study to give you a sense of the fact that researchers and clinicians out there are already talking about cannabis and its role in harm reduction. And hopefully some of these results will help to share a larger picture of what's happening in Massachusetts and nationally. So as another way of a little bit of background, as I said, this is the 8th study that I've been the principal investigator of, and every single study that I've conducted since 2018, cannabis consumers and patients have always reported using cannabis to reduce some type of medication or other substance. Back in 2019, I conducted a study. I was the principal investigator with several colleagues called the Veterans Health and Medical Cannabis Study. And gratefully, due to Dr. Johnson's leadership at the Cannabis Control Commission, this was able to be published in the peer-reviewed literature, which is very difficult. So thank you to Dr. Johnson for facilitating the clinical therapeutics issue. But in 2019, conducted a study that was a cross-sectional self-reported survey of veterans, 510 veterans, asking about their health conditions, their medical treatment, demographics, and their cannabis use. Out of these 510 veterans, 30% of the population reported they were homeless. And of the primary health conditions that veterans reported facing in our study were chronic pain, followed by PTSD, anxiety, and depression. The majority of our respondents used cannabis daily, and 30% reported that they were using cannabis to reduce the use of over-the-counter medications, antidepressants, anti-inflammatories, and muscle relaxants, and more. 91% of our 510 veterans reported that medical cannabis use helped them experience a greater quality of life, and 21% reported using fewer opioids as a result of their medical cannabis use. So in sum, veterans in our study, in this study, reported that they faced both physical and mental health conditions where they report cannabis is helpful in treating and reducing unwanted medication use and providing a much greater quality of life. When we asked these veterans about their medication and substance reduction using cannabis, again, we had a majority sample that are consuming cannabis daily or multiple times a day, and 46% of those veterans reported using less alcohol, 45% fewer overall medications, and 24% less tobacco use. Now, what does this mean? Cannabis is a non-lethal substance, and in this sample, veterans report using more harmful substance less as a result of their cannabis use. So that, in effect, is harm reduction. Well, we wanted to really drill down into a little bit more nuance to understand what was the likelihood of a veteran's desire to reduce their prescription drug use or using medical cannabis in place of other drugs. And so we ran binomial logistic regressions and found that veterans who were Black were 3 times, female 2.3 times, those that served in active combat 1.8 times, and those living in chronic pain 2.3 times more likely to report a desire to reduce the number of prescription medications they were taking. Again, as we heard in Dr. Johnson's presentation before, drilling down into the nuances of this data is really important so that we understand how we are treating specific populations and groups of people who have interest and in the nuances of desire to reduce ongoing medication use. Women were 3 times more likely, and individuals that used cannabis daily were 2.3 times more likely to actually report active using cannabis to reduce prescription medication use. So the implications are that clinicians should be mindful of the associations and the nuances and the intentions around a medical patient's desire to use cannabis as an alternative. So all of that is by way of background to really lead up to why we conducted this study. So about a year ago, connected with Kristen, and we talked about some of the results of all of these studies over the last few years, and said, okay, well, veterans have been reporting, using cannabis as an alternative, and some of the other the earlier study I did in 2018 with basic cannabis citizens and consumers and patients also reported using cannabis to reduce unwanted medication or substances. So we thought, well, let's drill down a little bit more and to understand some more nuances around this topic. And so we launched iCount as an alternative research study. So the objective of this study was to understand how consumers and patients consume cannabis as a way to reduce the use of unwanted other substances, including prescription drugs, alcohol, tobacco, opioids, and other recreational drugs. So we launched a cross-sectional national population-based research study of cannabis consumers and patients that either have used medical cannabis in the past to reduce substances, or they're currently using medical cannabis to reduce substances or mitigate withdrawals from substances, or if somebody has never consumed cannabis or opioids in the past, but had a desire to learn about how medical cannabis can be used as a harm reduction alternative, we also surveyed those groups of people. The data was collected from August 15th until November 23rd of this year, so it's very recent, hot off the press. We had 586 respondents to our survey, and a very high, surprisingly high proportion of our respondents face housing insecurity, with 41% reporting having been homeless in the past and 28% reporting being currently homeless. We also had a high military population, with 28% veterans responding to our survey and 21% active service duty members. We also had 28% of our sample identify as disabled, with the majority of our sample being white, followed by Native American, then Black, then Latino, and Hispanic American. A striking 53% of our sample reported that they have either faced opioid use disorder or been diagnosed opioid use disorder in the past. Another surprising statistic that came out of this study for me was that 65% of our respondents were between the ages of 25 and 36. It's a very, very young population. So when we asked, how would you describe your relationship to cannabis? 20% reported that they are a current recreational cannabis consumer. 20% reported that they're both recreational and medical cannabis. And 19% saying that they are a current medical cannabis consumer. When asked about the circumstances for how they currently use cannabis, which is all interesting, how people self-identify as a cannabis user, a recreational or a medical, we asked, do you have a medical cannabis card? And 30% said that they did have a state-approved medical cannabis card. 20% only recreational, again, 17 consume both medically and recreationally. So what we were really interested in this population is a population of cannabis consumers that were intentionally, and patients that are intentionally using cannabis to reduce some kind of substance, and or they had interest in learning more. 76% of our sample reported they've used cannabis as an alternative therapy for health conditions and symptoms, both currently and in the past. And when asked what are the most common conditions that cannabis is helpful in treating, you can see it's a similar profile to the veteran study results that I reported, except for PTSD is a little lower on this list. But 27% reported chronic and severe pain, followed by depression and mood, then anxiety, then PTSD, nausea, vomiting, and so on. When asked, are you using cannabis as an alternative for prescription medication use? half of our sample reported taking prescription medications, and when asked which of the following medications are you using cannabis to reduce, the top one is over-the-counter medications, followed by antidepressants, mood stabilizers, muscle relaxants, opioids, anti-migraine, beta blockers, sedatives, statins. You can see the wide range of different medications that people are using cannabis to substitute, and that goes along with the wide range of health conditions and symptoms that people are facing that are finding value in cannabis and providing some relief. Drilling down into opioids specifically, half of our sample reported either being formally diagnosed with opioid use disorder currently or in the past. 69% of the participants used cannabis to self-treat opioid use disorder. 54% used cannabis in the past to reduce the use of opioids, and 12% were not doing so but were very interested to learn more for themselves or somebody else. When we asked specifically what type of opioids or narcotics are you using cannabis to reduce the use of, fentanyl, which is a very dangerous, highly potent synthetic opioid that is plaguing our market right now, was the top at 37%, followed by codeine, morphine, Vicodin, heroin, hydrocodone, Percocet, oxycodone, methadone, and then xylazine. And I keep bringing up xylazine as it's a strong concern of a really potent drug that is entering the market here. And it's encouraging to see that people were reporting not using that with cannabis. We also asked, are you reducing the use of other substances that are more harmful or lethal than cannabis? And 62% reported using cannabis to reduce the use of tobacco, 58% using cannabis to reduce the use of alcohol. Additionally, we asked, are you trying to reduce any other substances? And we got a very interesting response. 27% using cannabis to reduce caffeine use, followed by cocaine use, crack cocaine use, DMT, LSD, kratom, ketamine, methamphetamines, amphetamines, and MDMA. So the key takeaways here, the opioid crisis is growing. It's growing nationally. It's growing in Massachusetts. There's a real need for innovative solutions to address it. We're in a state that is a leading force with Governor Healy, who has taken a strong stance against the opioid epidemic. So we have an opportunity to implement potentially innovative methods that not only intersect with the growing opioid crisis, but our growing homelessness crisis here in Massachusetts. Medical cannabis has been shown in clinical and public health settings and in the peer-reviewed literature to play a harm reduction role. It's a first-line therapy in Canada and other states instead of introducing other pain medications. And there's supporting evidence in the peer-reviewed literature and evidence here locally that would support a pilot project or really exploring this area further. In our study, participants reported reducing opioids, alcohol, tobacco, recreational drugs, prescription drugs, and reported improved quality of life. And with this epidemic accelerating, exploring the integration of legal cannabis into our clinical and public health programs has both clinical and public health merit here. So I will leave you all with a call to action. This was a small research study, but mighty one, conducted here nationally and here in Massachusetts, and we're looking for your help. We will be sharing these research findings with the Healy administration and other key stakeholders here in Massachusetts. And if you're a cannabis consumer or patient using cannabis as an alternative or not, if you're a researcher, if you're a healthcare provider, if you're a policymaker, a funder, a cannabis implementation partner, a dispensary, a member of the media, we ask your help in helping us to disseminate these study findings. We think that they're really important and that the wider audience needs to hear, and our small nonprofit appreciates any support to get the word out. What we would like to do is take these findings and move it into a pilot project, which would be an actual clinical demonstration project, where we could then work with Dr. Grinspoon, Dr. Stacy Gruber at Harvard, and other clinicians that might be of interest. These are my collaborators, along with Eva and other colleagues, to take this into a clinical pilot project where we could actually do a little bit more non-epidemiologic study, but really dig down into more rigorous research designs and to show the clinical efficacy of this kind of approach. So please do contact me if you're interested in this or interested in helping us get the word out about these findings or expanding into a new pilot project. So thank you very much, and appreciate the time and attention.
Thank you, Dr. McNabb. We have some time for questions now. Just raise your hand and I'll give you the mic. Miyabi.
Marion, thank you so much. And I love it. Like, I'm so proud. I've known you since 2018. Thank you for your work. Like, this is incredible. I had a question about the other substances and what the criteria was for including more harmful substances. I'm currently on a microdose of LSD. I consider the use medicinal for neurodivergent brains. And I just was wondering about that criteria of, what substances and how you chose to classify them.
Yeah, it's a very interesting question and a very good question, because there are some substances that are medicinal, and then there are some substances that are medicinal and can also have the level of abuse or misuse. So actually, this was a contribution of Eva, and that's my colleague, the co-investigator, really trying to understand what street drugs are out there. So we took a list of tested street drugs that are out there, and that's what we used as our laundry list, not necessarily whether or not it was medicinal, had medicinal qualities or not, because ketamine also is a potential, or mushrooms, psilocybin also has that medicinal potential. So we literally just took a list of what street drugs were out there, but didn't do that next level of asking them whether or not they were using it for medicinal use or for recreational use. So it was a self-select survey. So basically it was a question, are you consuming any of this? And didn't make that nuance. But,
awesome, thank you.
Yeah, I'm so happy to see you here and your work.
Hi, Dr. McNabb. Thank you for your presentation. It's very enjoyable. First of all, I've got to react because these findings are so statistically significant that anyone looking at them would be instantly convinced, one would expect. And yet, on the other hand, I'm dealing with medical cannabis patients every day, and I have a large number of patients that can't get any products that contain even the slightest amount of THC in them because they're going to a pain clinic, and the pain clinic has told them that if they test for any amount of THC at all, that their pain medications would be cut off. And this has actually happened to some of these patients. And I think it's just incredibly cruel and incredibly cold-hearted that anyone could do that. And I know there's no answer how we can get these people to stop doing it, but that's one of the things that's driving new addictions, is that the medical community itself, in rejecting this substitute therapy, cannabis substitution therapy, are continuing to drive people into the opioid market. And it's just incredibly frustrating. I don't know, is there any advice? Are there pain centers that don't do these kinds of things?
Yeah, you make it a very excellent point, and this is the biggest challenge because it's criminal to cut people off of their opioids, and it's a real problem. I do know from the veteran study that I've worked on, one veteran has told me that there is one pain clinic in Massachusetts where they can get their pain meds and have cannabis at the same time. That's one pain clinic in Massachusetts. I think the biggest problem is a lack of education among our healthcare providers, and especially among our substance use and addiction specialists. There's a really strong funding stream, history of prescriptions among providers, and incentives among healthcare providers to prescribe pain meds, hence the suing of the Sacklers and the Purdue Pharma and the history that we now stand here. I think we need to educate our healthcare providers about it. Specifically, we need to educate our addiction doctors. Two, I also think with more and more, the continued legalization and more awareness of the value and the research findings around medical cannabis and getting this word out that the data exists, these are things that are happening in other places is really important. And then, having some, state level support around, wanting to encourage research or inquiry into this, I think would be great. Other states have implemented, I'll give you an example. In Illinois, they implemented a pilot program where you could take your opioid prescription and you could get cannabis at a dispensary instead of your opioids. That's something that we've proposed here, or recommended here as a bill. It's actually a bill in the State House right now. So if anybody wants to support that, to introduce a pilot project like that. I think also giving clinical standards and guidelines for clinicians around it, that's evidence-based, will be important. So things like this exist in Canada, treatment protocols, at some of the publications that I had on one of my slides that says, okay, well, this is when you can introduce cannabinoids, and the different ways that you can do that and how you monitor your patients. So for a long-winded answer, I think it's education of the providers. We need some state leadership. We need some funding. We need some pilot projects here that really look at the clinical level and not just this high-level epidemiological data. But we are up against the pharmaceutical industry. And cannabis industry, I don't know where it is in making money over the pharmaceutical industry now, that we're at like $5.9 billion, but some investment in this area for further inquiry would probably help.
Hi, so I guess my main question would just be, for these studies, was this mainly THC dominant flower, or was it a mix of everything, or is that something that you plan on looking at in the future?
That's a great question. I have a research study in my back pocket that would look at that. But this study was actually just self-reported. If you were a cannabis consumer or patient or you had interest, we didn't, excuse me, we didn't ask what kind of cannabis, what strain, what dose, and all of that associated with this. This was a very light touch, sort of high level study, but that is a very interesting point. And there's some colleagues that have done some detailed research in other states with dispensaries that I was trying to get going here, where they're looking at the prescription drug monitoring data that comes out of our state and then matching that with dispensary purchases, anonymizing it through some really cool HIPAA compliant ability to do so. These are really advanced data science people. And they have some really interesting findings that are showing what types of cannabis, what cannabinoid profiles, how much THC, how much CBD people are using to reduce by opioids. So they could say, okay, we're trying to reduce Vicodin, and this person is choosing to do an edible and in this cannabinoid ratio. So that science is out there. I hope that we could integrate something like that here. Hopefully with the new coordinated data systems at the CCC level, if you can pull in data from other sources, this could be a cool project. But very good question.
Got time for one or two more?
Thank you for your presentation. I just was wondering, do you see there being a role for nurses in upcoming research and implementation, especially with the ANA acknowledging cannabis as a specialty?
I'm so glad you asked that question. A couple years ago, yes, absolutely. I think nurses will play one of the strongest roles, in addition to maybe even a community health worker or like an ancillary nurse, because you are the nurses and are closest to the patients. They know more nuances than a physician. A couple years ago, I ran a healthcare provider knowledge, attitude, and practice study about medical cannabis, and the nurses came through strongest, knowing the most, having the most connection to patients. So yeah, absolutely a role. I also think that we need to work with our nurses to, really train our substance use counselors, and at the point of entry, when you're doing intake, to the point earlier, somebody's kicked off of their opioids because they're using cannabis. So starting at that front line, which is nurses, counselors, equipping and empowering them with the knowledge, but also the ability to negotiate and to explain to a prescribing entity about the value. But the challenge is that cannabis and the endocannabinoid system still isn't taught in medical schools and nursing schools. I think it's around like 20% or less of medical schools actually teach about the endocannabinoid system. So we have a lot of work to do there, but it's forums like this at Harvard and, that we continue to try and bridge that advocacy and call to action.
All right, last question.
Sorry?
I imagine those schools would cover the vascular system,
Yeah.
the nerve system,
Or the immune system?
the other body-wide system.
Yep. Just for a little bit of background about why they don't. So medical cannabis was taught in medical schools. It was in our pharmacopoeia in the early 1900s and was systematically removed out of our pharmacopoeia and our medical education right at the time of Anslinger and all of the start of everything. So it used to be taught in medical schools. But.
So as a cannabis cultivator, I kind of try and consider myself as a plant doctor, and they would be my patient. And so being able to put in the proper care and love and appreciation to the plant is how I would be able to achieve the most high quality product. And the data sets that you're looking for have too many variabilities based off the substance that the people are trying to substitute for the opioids and whatnot isn't as standardized and continuously produced with that type of care. So every person, that's like saying alcohol versus Jameson and other types of alcohol that are continuously produced at a standardized rate where it's like Coca-Cola is Coca-Cola. And so I think if potentially some of the data sets that you're trying to achieve the information, if in the first place, everybody was consuming a very standardized same type of refined product versus smoking it, you may find a more accurate results that you're looking for.
Yeah, I think you make a very good point. The cannabis and our health is very nuanced. So cannabis and how you cultivate it, all of its phytocannabinoids, all of its terpenes, all of its cannabinoids, all of those combinations actually are very unique, right? There's like over 400 compounds that are interacting here, right? So then to the point where you're caring for it, making sure it's cultivated, cured, you got all the right terpenes and done it really well versus you're manufacturing it out like... Yeah, and there's a big difference there. I agree with you 100%. There's also the big difference that when you're consuming it, how that interacts with your own body and your own health conditions. And that in itself is its own personalized medicine. So there's a personalized medicine in making the medicine, and then there's a personalized medicine in taking the medicine. So I could have anxiety, you could have anxiety, we could take the same thing, and we could have vastly different. So it's very important for the industry to understand and also the consumer to understand, because the average consumer doesn't really realize, I think, all of these nuances. And, in our industry now, maybe a lot of our consumer choices are either driven by price or branding and not necessarily the quality of the product or what product you're getting. So it rolls back to a need for a larger education campaign around what does this really mean and what does this mean for you? And and the importance of the consumer knowing what product you're getting and how is that going to impact.
Fantastic presentation. I am so thrilled by you continuing to do these grassroots to fairly fantastic research, really focused on veterans and populations that kind of get brushed aside. And I just want to kind of say that these efforts are so important to what we do. Cannabis is not the same as alcohol and tobacco. It is very different. It's very different from historical structures. We are still, and everything really does count. I'm really mentioning you said that because with the pharmacopoeia, we used to have cannabis. This all is an impact factor of the war on drugs. And we are battling this in all kind of society structures. And so to be able to do this research is so critical and in different capacities, and we need to all be on the same table and doing it together. Because what we don't have right now, and I've talked to a few people in here, we don't have the basic science. So policy is moving ahead, and we're adding all of these things, we're doing all these, really innovative things, but at the end of the day, we don't have the basic science. We don't have the milligrams of THC versus CBD versus, the key cannabinoids that we know about and those impacts on very different illnesses. I am really concerned about this for medical patients and the sustainability of programs, especially with adult use come on, because yes, I don't think patients know what they're using, how they're using it, what are the differences in modes of administration. There's so many questions, and this research needs to be done. This research is hindered by the federal level because of the scheduling status, right? But there are creative ways. You are, leading this and, different and finding creative ways to look at these studies or look at these issues, even though we have this hamperance of the federal one. the Schedule 1 unfederally. And I guess that's my ploy to everyone here, is to really work together. We really are on the same team. We're trying to do the best thing. We are trying to do what's right. And I really want, in my capacity as the Chief of Research at the Cannabis Control Commission, is to help lead that science, is to help you have the data, help you do this. And I really just kind of want to echo that we're on the same table, we're on the same team, and we really do need to help each other.
Thank you. Thank you. Yeah. I appreciate the collaboration.
All right, thank you everybody for the great questions. Let's hear it one more time for Dr. McNabb and her fantastic research.